So welcome to this fourth webinar hosted under the Global DAT Task Force's Learning Hub. For this fourth webinar, the topic is on differentiated care through digital adherence technologies. So as a part of the Global DAT Task Force, we're hosting a whole series of webinars that focuses in on very specific topics to give countries a more comprehensive insight into what digital adherence technology planning entails. And so if you've missed any of the previous webinars, please go ahead and look at our website, because all the recordings are on the website. And then I'd also like to encourage you to register for any of the future webinars that we will be hosting. So we host one webinar per month at the end of the month, focused in on topics that are important for countries. So to kick us off, I'll provide an outline for the session for today, and then I'm going to hand over to my colleagues. So in terms of introduction to differentiated care, we'll be looking at some of the theory behind it. So just an overview of what the different digital adherence technologies are, then what a differentiated care pathway is, and then lastly, looking at how a differentiated care pathway can be used in action. Then the second presentation will be from Yunus Moturi, who is providing experiences from Tanzania. And then lastly, Vladimir Kochanov will be providing experiences from the Ukraine on differentiated care. So with that, I would like to hand over to Rachel Powers, who is a digital health consultant at KNCV, and she'll be providing the theoretical background. Thanks, Rachel.
Thanks, Ines. Good morning, everyone. Glad you could join us for the webinar today. I'm going to introduce you to the idea of differentiated care, and then we can look a bit into how to actually apply that for users of DATs. So as an introduction, we know that people living with TB have diverse experiences and challenges that impact how they take their TB treatment and how adherent they are during their treatment. So we know that different people may require different levels of support at different moments. There is no one-size-fits-all approach when it comes to TB treatment. So when we talk about differentiated care, we are looking at how we can combine technology automation and healthcare provider actions to really give the best benefit for those undergoing TB treatment, to provide flexible, timely, and resource-efficient adherence support. So differentiated care as applied to digital adherence technology intervention. So before I dive into more details on differentiated care, I just will give an overview of what we are talking about when we're talking about digital adherence technology. So in this presentation and in most of the work that we and our partners are doing, we're talking about three different DATs. That is the smart pill box, medication label, and video supported treatment. So with the smart pill box, people undergoing TB treatment will keep their medications in the box. When they open the box to take the medication, there's a sensor in the box that sends a signal to the platform to indicate that the box has been opened and the medication has been taken. This intervention requires no additional technology other than the box on the side of the patient. For video-supported treatment, a lot of you are probably familiar with this. It can be a formal app, such as Assured here, which is specific for TB intake, or it can be something like Skype or Viber, WhatsApp, where people are recording a video of themselves taking their medication and then sending it to their provider for review. And then last, we have the medication label, where TB patients are receiving their medication, and on the medication blister pack itself, there's a label, usually with a code or a phone number to call. And this is a toll-free message that they send or call that they make, and that logs that they've taken their medication for the day. So when they take the medication, they send that toll-free message to the number. And it's important to note that with this intervention, a phone is required on the part of a patient. It can be a feature phone. It doesn't need to be a smartphone, but for medication label, a phone is required. And of course, for video supported treatment, a phone is required. So keep that in mind when we talk about the different technology interventions we can have. Now, before we move on to the rest of differentiated care, I do want to note that also it's not only these 3 technologies that include a DAT intervention. All of these require an adherence platform that this data of adherence is going into. And this is where providers will look to see what the adherence has been. They can look for patterns in adherence, and they can potentially look at the records of those persons living with TB. And just to note that there are several platforms for adherence that are currently available. There are some new ones that have entered the market. One is the DHIS2 tracker app integration. There's also a new smart pillbox direct API integration, and the Shared Here Dimagi platform now supports pillboxes. And then, of course, the existing platforms we have are the Wise Pill Sense platform that supported the pillboxes, Ardex supporting the pillboxes, Shared Here for VST, and then Everwell Hub, which was a combination of medication label, VST, and smart pillbox support. So now that we've covered the introduction to DATs themselves, let's talk about what we mean with differentiated care pathway. So when we talk about this, we want to think about a series of either automated or manual actions that are triggered by a patient's daily adherence. And this is all intended to help understand how adherent that client is being so that we can provide support as needed, or the healthcare provider can give support where needed. So if you look here at the graphic, we're imagining the green days are days that where adherence has, dosing has been successfully reported. And then on this red day is the day where the client did not report their dosing. And so adherence support action would be warranted, hopefully to then bring the client back to adherence and continue treatment. Okay, so when we're talking about actions for support, we're actually thinking about 2 different categories. One is technology automation, and the other one is manual human action. Before the intervention of DATs, a lot of the support was only manual human action. But with DATs and the technology supporting them, we can think about how technology can be leveraged to also support these clients. So if we think about technology automation, that's things like SMS reminder messaging. It can be visual or audio cues. For instance, on the smart pillbox, there's an LED light and a small speaker that can give an alarm. We can also think about in-app notifications for things like Shared Here or I Love VST app. When we're talking about manual human action, that's things like a provider call or an SMS to a client. It can also be a home visit to a client, or potentially additional counseling for when that client is at the health center, or requesting the client to come in for additional support. So if we think about support actions, we also need to think about what is the trigger for this action? When do these support actions need to happen? Based on what? So we can think mostly about how the client's adherence pattern may trigger a support action. So if you think of someone who has not reported their dose for that day, maybe it's the end of the day, they could get a reminder message because they have potential of missing a dose. If they have missed reporting a dose, maybe the next day they could get a message or an in-app notification. Then you can also think of what would 2, 3, or more days of consecutive missed doses mean? Would that be a different support action than one day? Would it be a home visit, for example? We can also think about a trigger being something like the length of time on treatment. For example, maybe there's a motivational message that comes after 2 months of the client completing treatment. Or you can think of other triggers, such as medical data. If there's a test, a sputum test that the patient needs to come in for, maybe that would trigger one of these automated or manual actions. So let's look at some of these examples. So I described earlier, potentially an evening automated SMS that's a reminder for someone if they have not yet taken their dosage for the day. So We know typically TB medications can be taken in the morning, especially if it's for DSTB. So you can think about if it's the end of the day and someone hasn't reported their dose, maybe they would get a message to remind them, okay, don't forget to take your dose, text it in or open the box. And that could be something like an SMS. It could also be something like an in-app notification or an alarm from the box. And this would be a technology intervention. Now, let's say that the client unfortunately did miss reporting their dose. The next day, they could get a message or a reminder via SMS or again via box queue or in-app notification. And it could also trigger provider support. So maybe it triggers a call to the client. Hey, I see you missed your dose yesterday. Is everything all right? Is there any additional support that you need? And we can also think about if there's more consecutive days of missed doses, what kinds of triggers, what does that trigger in terms of support? Is that still a message to the client? Does it trigger a home visit instead? And are there different messages that are sent via their phone message or via the box? We can also think about some automated technology interventions to actually support the provider follow-up for that client. So this is an example from what we call task lists, and we use this with the Ascent project, a 5-country project. And these were automated lists that were provided to the TB worker. And it was trying to support them in following up with patients. So if you look here, for instance, at the follow-up call needed, this was a list of clients who have missed their day's dose yesterday and require a follow-up call. So that would be a sort of actionable list for the provider to take those actions. These can be useful also for helping streamline support actions from the health system. Now, in addition to adherence or not adherence, there can be other triggers for automated support and communication. So when a client is initially enrolled on the DAT intervention, once they've had their treatment counseling and they've started on treatment and also with the DAT device, they could receive a reminder message on their phone. Welcome, this is you've been enrolled on the DAT. If you have any questions, please reach out to your healthcare provider, for example. You can also think about reminders for upcoming visits. So either a reminder message from to their phone, or you could even have an alarm that's programmed into the smart pillbox. What I mentioned before, you could say that a length of time would trigger something like a motivational or educational message. Perhaps after reporting 50 doses successfully, there's a sort of congratulations or motivational message to make sure that that client feels supported in their TB journey. And you can also have things that support the technology itself. For example, a low battery alert for the smart pill box. So using the lights on the box to indicate that the technology itself needs some attention, the battery needs to be charged, example. So I want to briefly show an example from the Philippines. I don't expect you to be able to read the small text here, but I've blown up part of it on the right-hand side. But this is a visual of the actual differentiated pathway flow chart that the consortium in the Philippines put together to support patients. So when you start, you have the series of yes/no decisions. Did the patient take their dose for the day? Okay, then it's reported in the hub adherence platform, and that's all fine. But if they didn't take their dose, do they require a reminder message? Do they require a message to say, oops, you missed your dose, we're going to follow up with you? So this is how that flow chart looked in terms of capturing all of the actions that would take place both on the technology and the provider side. So on the right-hand side here, you can see that in the Philippines, we did have this reminder at the end of the day. So if the client hasn't reported their dosage, either from opening the box or from texting in the code, they would get a message at 6 p.m. saying, looks like you haven't taken your dose today. Please don't forget to text the code, or please don't forget to take your medication from the box, depending on which technology they were on. And here you have an actual example of that message. So you can see here that this was sent to the client at 6 p.m. It's in Tagalog, but you can see that it's talking about TB, and it says, please text the code. And then it has actually triggered the patient to text the 3-digit code for that day to log their adherence. Here's another snapshot from a large document that we had supporting the 5 countries of the Ascent project, where we laid out each of the different differentiated care actions and triggers that took place for each of the countries. So this is a snapshot from Tanzania, and Eunice will talk more specifically about the Tanzania intervention shortly. But you can see here that depending, you have a column for DAT, so depending on the DAT, there were different triggers that would happen. So for medication sleeve, if the patient dose is registered on the hub, then there would be an SMS confirmation to the client. Then you also see things like with Smart Pillbox. Once it's the patient is registered on the pillbox, they get a welcome notification. And then for all of the DATs, we had similar follow-up after 1 missed dose, 2 missed dose, and these could be an app notification, SMS, to the recipient, and there's also messages to the provider based on what kind of support they're required to provide. And in this, I wanted to give a reminder that it's really important when you're looking at creating differentiated care plan to map out the users, the context, and the specific actions to be taken and when. So you can really understand what role you want the technology to play and what role you want the human support to play. Because then in essence, they shouldn't be separate, but they should be working together to provide support to those clients. So I'll wrap up here with just some key questions to answer when we are looking at creating differentiated care pathways for a DAT intervention. So starting with key questions to answer for technology. So first you have to take an inventory. Which DATs are you actually using, and what are the tech automations that are possible there? If you have someone that's already using VST, then you know that they have a phone. You can do things like SMS or other sorts of messaging. You can do in-app notifications. If you have someone who's using a box, you know that you can use the box lights, LED lights, alarms from the box, and those can be interventions for the patient on the smart pill box. You can also think about, depending on the platform, what kind of task lists you might want to create for the providers giving support. You also want to think about number 2, do you actually want to include automated messages to patient phones in your approach? So not all clients will have a phone. Knowing that, do you want that to be a key part of your intervention, or will you have other methods of making sure you can provide support? You also want to think about, will people respond to the messages? In some contexts, there's a lot of spam messaging that happens just in general, a lot of notifications that people are getting. It might make them less likely to pay attention to the ones around adherence. So is it better to then focus the technology automation on one that's more relevant for that context? You also need to think about what are the triggers in your system and what actions follow. So this is where you map out, what does 1 day of non-adherence trigger? What about 3 days? Is that a different kind of support action? And when is an in-person visit to the client needed? When is that human touch in person really required? Now, answering questions around provider support and how to do those manual actions to support the clients. So if you think about what follow-up actions are feasible for providers in your system and on what schedule. So there's a lot of ideal situations that we can think about that, after 1 day of non-adherence, maybe there would be a home visit or a call, but we have to think critically about how feasible is that for your TB providers, for the nurses, for the volunteers supporting the patients in that context. And is that actions that we can count on in the system, or do we need to make sure that what we're designing is really feasible for the context we're looking at? We also want to think about what mechanisms are already in place for in-person support and how can those be leveraged. So are you working in a context where there are community health workers already supporting persons living with TB in the communities? Do you have facility volunteers that could potentially help with phone calls? What are the other resources that you have, the capacity that you have in your system to provide that manual support. And then lastly for this, are there additional human capacity resources that are needed to reasonably achieve your intended differentiated care pathway? I'll speak again about the example from the Philippines. Originally, we had imagined that the TB nurses would be able to do these phone calls and then communicate with the patients and arrange home visits if needed. But then we saw that what really was not feasible to rely just on those facility staff to give that in-person support. And we then engaged with the barangay healthcare workers, the community healthcare workers, oriented them on the DAT intervention, and then asked them to help with follow-up to patients that had 3 days of non-adherence for a home visit. And lastly, I want to add with this key point as well. So when we're talking about designing a differentiated care pathway, you really want to make sure that it's acceptable for the NTP, for the stakeholders there, but primarily for the clients. So in the Ascent project, all of the differentiated care pathways were designed in partnership with CSOs and community groups. And so the key question here is which CSOs, networks of people living with TB in your community, which NGOs and relevant stakeholders can you engage with in the creation of an appropriate and acceptable pathway? And the key here is that for this pathway to actually be acceptable, of course, the technology needs to work and the human intervention needs to work, but this whole package needs to be human-centered, considering the needs of the stakeholders, but primarily with those clients, with those persons undergoing TB treatment. So with that, I will wrap up and I'll hand it back to Inez. Thank you.
Thank you, Rachel, for the presentation and the overarching theory. Sorry, just give me a second. Okay, so next up, I would like to introduce Yunus Moturi from Tanzania. Yunus is a public health practitioner with over 8 years of experience dedicated to public health, with a focus on TB programs. Yunus has worked with various international health NGOs and has been involved in digital health initiatives to enhance healthcare delivery and improve patient outcomes. She's worked in PATH Tanzania as the mHealth coordinator in the Challenge TB project, and she's worked with KNTV Tuberculosis Foundation as the Digital Health Technical Coordinator for the Ascent project in Tanzania. So with that, Yunus, I would like to hand over to you.
Thank you very much, Ines, for the introduction.
Sure.
I'll be taking us through the DAT differentiated care Tanzanian experience. My first slide is on the outline of what I'm going to present today. The current standard of care in Tanzania, the differentiated care pathway, the challenges we encountered while we were implementing the DAT, and the lessons learned and other findings. The current standard of care in Tanzania is implemented in 2 ways. There's home-based DOTS and the facility-based DOTS. For the home-based DOTS, this is where a patient is given medication to go with at home, and they take medication under the direct observation of a treatment supporter. And for the facility-based DOTS, this is where the patient goes to the facility on a daily basis and they are given medication under direct observation of the healthcare worker. Now, when those who have already chosen the option of taking medication at home, they usually go to facilities for refill according to the phases of treatment they're in. For example, the DSTV patients in Tanzania usually go, those who are in intensive phase go for refill on weekly basis. If a patient misses going for refill 2 consecutive times, that's when the healthcare worker will start doing the follow-up. Will make call to the patient. If the patient is not reached, then call the treatment supporter. If both of them are not reached, then a CHW will be sent to do the follow-up. So the follow-up is done after 1 to 2 weeks. That is in intensive phase. In the continuation phase, the follow-up for patients who have missed going for refill 2 times is done after 2 to 4 weeks. That's when the healthcare worker will send a CHW to go visit them and bring them back to treatment. For DRTV patients, those who choose the option of taking medication at home, they also do it as DSTB under the direct observation of a treatment supporter. And those who have an option of going to the facility on a daily basis to take the medication, they are also given medication under the direct observation of the healthcare worker. When they miss one dose, especially those who come to the facility, the next day the healthcare worker will call the patient or the treatment supporter to find out what challenges they're going through. And if they are not reached by call, then the third day, the healthcare worker will send a CHW to go and do the follow-up. That is if the facility has engaged the CHWs in that hospital. Yeah, and in the continuation phase, it's the same. Now, the introduction of the DATs, now the patients have the freedom to take the medication at the time and place where they feel more convenient. The patients now have reminders to remind them whenever they are unable to, they forget to take medication. The reminders which came along with the DATs are like automated messages, as Rachel's already presented, the calls, and also the home visits. We have to take note that the DATs came to strengthen the already existing differentiated care. We implemented 2 types of DATs, medication label and smart pillbox. And whenever a patient would take message and send the codes, especially those who are in medication label, and send the codes to the toll-free number, and that will be reflected as adherence on the adherence calendar that day. Just in case they don't take medication that day, in the evening, 6 p.m., a message will be sent to remind them to take medication. If still they don't take medication up to midnight, that day their calendar will reflect, will be red in color, meaning that the dose has been missed. The next day in the morning, 8, a reminder message will be sent to them. And if still they don't take medication, a healthcare worker will reach out to find what challenges they're facing. If they are not reached, the treatment supporter will be called. And again, if they are not reached, that day in the evening, a reminder again will be sent to remind the patient to take medication. And if the patient does not take medication up to midnight, it will also again reflect a missed dose, and the calendar will still remain red in color. The third day, after the reminder has been set in the morning and the patient has not taken medication, that's when the healthcare worker will do the call again and also involve the CHW to go home and do the follow-ups and find out what challenges they're facing and bring them back to treatment. This is a pathway of differentiated care where a CHW has been engaged in a facility. So this one is actually the same pathway, but this is a pathway where the facility has not engaged the CHWs. The only difference here is after the third day, the healthcare worker calling and not able to reach the patient, there's no sending of anybody except that they'll have to find time on their own to go look for the patient, do the home visit and counsel them and bring them back to treatment. And as we know, most of the time they're overwhelmed with work. That means they'll take time to go do the home visit. But the reminder message would continue being sent to the patient to remember to take the medication. Now, there are challenges we encountered when we were implementing the DAT. The first one was technological barriers. the internet connectivity. That was in both the medication label and even those who were using the smart pill boxes. For example, those patients who are living in areas where there was poor network, they could send and using the medication label, they could send the codes to the toll-free number, but again, it could not be reflected on the adherence calendar, and they kept on being sent for reminder messages, though they had taken the medication and sent the codes. That is just one of the internet connectivity issue. On the device like smart pill box, it could malfunction, or the alarms could malfunction, go off at the wrong time, or sometimes the battery could be over for the smart pill box, and the patient could not realize that the box does not have power anymore until they come back for refill. So this kind of internet technological barriers delayed the updates of the adherence of patients, because the healthcare worker now had to find time to call the patient, confirm if they have taken medication, and update manually the adherence. And this was also overwhelming them because they already have enough work at the facility. And also those patients who are sharing a phone number could not get access to use the phone on daily basis after taking medication. So that one proved a challenge. And some other patients used the phones which have more than one SIM card, and they forget and send a code to the toll-free number using one of the numbers which they have not recorded registered on the adherence platform. So it's again, whenever you call a patient, it says, I've sent the codes, and unfortunately they use the wrong number, and that one could only be recognized when they come back to the facility and they demonstrate in front of you which number they used, and you find out that they have used a different number than that one which was registered. So what we used to advise the healthcare workers to make sure that they register all the numbers that they can possibly use to send the codes. Another challenge was the literacy level. Some clients, especially the elderly ones, could not use medication label. They could not read or send the codes. So such clients were put on smart pill box. And also, most clients did not have airtime to be communicating to healthcare workers to inform them whatever challenges they were facing. If the side effects, for example, if the side effects they are having preventing them from continuing taking medication, or any other challenge they have. So the communication was only one way. The lessons learned and other findings. We believe there's a need to have a system which the patients could communicate to the healthcare workers without necessarily them being charged to send the messages or to make calls. Or at least we should have a toll-free hotline where the patients can communicate to healthcare workers whenever they encounter any challenges at home. Also, initially when we started implementing the DAT project, there's a pathway we envisioned to follow. But as we continue implementing, there are some things we changed, like at first, not all health facilities had the CHWs engaged. And we said we will just implement the way the facilities are. If they were implementing without CHW, we'll continue that way. We did not want to introduce new things to them. But as we continued implementing, we realized that the facilities which had the CHW were implementing better. Yeah, there were more patients on the platform. There were more feedback from the CHWs on the design or on the differentiated care. So they were more active on the facilities where the CHWs were. They were performing much better compared to the ones which did not have the CHW, because those ones with CHW had enough support. They could even help the healthcare workers doing consenting and even registering patients on the adherence platform. So we ended up engaging them along the line. This is where flexibility is needed and adaptability for DATs as we go along. It's needed as we receive feedback on how to improve the service. So flexibility is also needed. Also, another thing, we found out that it was a bit challenging to manage the intake of the DRTB patients' medication, because some of the medications were taken on daily basis and others were taken 3 times a week. And using the smart pillbox, that proved a little bit challenging. So we propose that maybe going forward, any country would like to implement DAT and enroll DRTB patients, that at least the smart pillboxes should have compartments for daily intake of medication. For example, Monday, Tuesday, Wednesday, and so forth, so that it may be easier for the patients to know which medication to take for which day. And also, we found out that there are some medications which, when removed from the original containers, the manufacturer containers, they lost their potency. So what we did here is to have a discussion with the NTP and the healthcare workers on the ground, and came up with a plan of making containers which mimic the original manufacturer containers, small containers, which were put in the smart pillbox with the medication of a weekly dosage. So to some extent, it helped, and at least we were able to enroll some of the patients to the DAT. Also, these patients were having self-stigma whenever they go to the facility and they were enrolled on the smart pillbox and they carry the smart pillbox home. They felt like people were curious, and they were discriminating them, wanting to know why they're given such boxes. So because of this self-stigma, and we wanted the patients to be comfortable using the smart pillboxes, we had to make bags for them to carry, translucent bags to carry the smart pillboxes. So those are some of the findings which we came across as we were implementing the DAT differentiated care.
Thanks, Eunice. Really appreciate it, and a nice in-depth understanding of the Tanzania context. So now we have some time for questions and answers. Just one comment that I want to make while we wait for some questions and answers was Eunice's point on people on or with DRTB, and that there was a challenge in terms of the dosing complexities and how we use the smart pill box, and the recommendation to have pill cartridges. So following on from that, we did some work with the manufacturers of the smart pill box. And as of this year, you can procure pill cartridges directly through the Global Drug Facility, along with the pill boxes. And this is really to enable people with DRTB to also make use of the smart pill box, as well as people using, Rachel is showing it, as well as people that are using BPIL. So you can see, are you able to drop it down a little bit, Rachel? Just down a little. So you can see that there are 7 days worth of dosing that you can place into those boxes. And we've tested it with a number of DRTB medications. And basically, a day's medication fits into one of those cartridges, as you can see on Rachel's screen there. And then you could fit up to 7 cartridges into the pill box. We suggest fewer, so that patients don't have such a long time between health facility visits. But either way, you could fit up to 7 weeks of cartridges into the pill box to make sure that that patients are supported in terms of the dosing complexity aspect. So that's just one comment that I wanted to make based on that. So the question is, did you manage to do a head-to-head comparison of an adherence support intervention that included community health workers and paper-based tools, i.e. a TPT card, versus an intervention that included community health workers and DATs? If yes, what was the outcome? So Eunice, I don't know if you're able to answer to this particular question that's posted in the chat.
Maybe let me invite Baraka if he has a response to that.
Oh, yeah. So, yes, I think that was because Ascent basically was the research implementation project, and we were really looking at the effectiveness of the DATs compared to the standard of care. If those usage of DAT really have any impact on the treatment outcome. I think the results are now compiled, and soon we'll be publishing them. But in a nutshell, it didn't show much difference in terms of the treatment outcome of the patients. But commenting to the adherence is really, you can see the improvement where there is a DAT and differentiation of care. There were a huge difference in terms of the adherence, but you can't tell on the adherence specifically for the standard of care, because there is no any way to monitor whether they are taking or not. Only that you will tell that on the final treatment outcome, which didn't show much of the difference. I think that is what I can comment on that. Thank you.
Thanks, Baraka. Then one other question is, do we have outcome data on adherence and TSR before and after intervention? So treatment success rate before and after intervention. Eunice, are you able to answer that one?
Yeah.
Oh, I see that the question has been answered.
Oh, okay.
Thanks. Thanks, Eunice. I don't know if you want to add any more inputs in terms of what Baraka said.
No. I was just saying, in case of any additional information they would like to get about the outcome of the research project, maybe until we get the full paper, the main paper, that's when they can, I think it will be shared for people to read. Yeah.
Yeah, great. Thanks. Thanks, Eunice. Then I see that Rachel's hand is raised. Rachel, please go ahead.
Thanks. Yeah, just to comment one more thing on the research side. So with the 5-country Ascent project, as Baraka mentioned, there was a few different research questions that we were trying to answer. One indeed was around reduction of poor treatment outcomes, but we also looked at acceptability of treatment to patients for the DAT intervention, and there was also some costing study research around whether the use of DAT helped reduce costs for patient in terms of facility visits, et cetera. So there's a number of papers that are being reviewed right now and ready for being published. So just to mention that outside of the effectiveness, there were some other elements that the research looked at as well. And so part of what we have been, the results of this research have helped us do a lot of thinking around, what are the benefits of DATs? If there hasn't been a landslide difference in the end of treatment outcomes, are there other ways that they're really beneficial for people living with TB and for providers that still make them useful interventions? And that's something that we're thinking about with this research, and happy to share the research results with you as they are published. And I think they'll probably also be published on the Global DAT Task Force website as well. Thanks.
Yeah, indeed. Thanks, thanks, Rachel. I did just want to say that the research will be published on the DAT Task Force website, as well as on the Ascent project website. Just one last look at any questions. No, I don't see any additional questions for now. So if you have any questions during the next presentation that are still unanswered or that you would like to have a response to from Eunice or Rachel, please feel free to post them in the chat. So with that, I would like to move on to Vladimir Kokhanov. He is a program specialist at the PATH Ukraine, and he has more than 7 years of experience working for donor-funded projects supporting TB and HIV control efforts in the Ukraine. Vladimir has been supporting the implementation of TB digital adherence solutions in Ukraine since 2018, and currently he's supporting the implementation of DATs in the region and promoting person-centered focus and tailored support mechanisms to empowering people with TB to achieve their treatment adherence. So with that, Vladimir, I'm going to hand over to you. Are you able to take control of the slides yourself, or would you like me to go through them?
Thank you, Ines, for the introduction, and I'm trying to take control.
Yeah, you've got control now.
Yes, I've got control. Thank you.
Yeah.
Greetings, everyone. And with my presentation, I would like to guide you through the journey of the implementation of digital adherence technologies in Ukraine, with highlighting the differentiated care algorithms we tried to introduce to support people with TB. So I will start with the background and highlight our experience from the very beginning of the introduction of digital adherence technologies. Then I will switch to people-centered approach and differentiated care practices and best lessons learned. In Ukraine, historically, there were two prevailing outpatient treatment options, which were facility-based directly observed treatment, which involved observation either at the region-level hospital or TB dispensary, or smaller treatment units like district clinics or so-called DOT cabinets. Another treatment model was home-based DOT, when a social worker or nurse visited patient at home to administer treatment and deliver TB drugs. But this second outpatient treatment options was limited by the funding. In Ukraine, Ukraine receives funds from the Global Fund, and organizations, usually local organizations, who are prime recipients of these funds, distributing these funds among civil society organizations which could support patients with special needs who can administer treatment at home. As in 2017, the WHO publishes its first recommendation on the using of digital adherence technologies, conditional recommendations. The National TB Program pilots video-supported treatment using non-specialized apps like Viber, WhatsApp, or Skype for administering video-supported treatment with patient. And the COVID-19 epidemic, the health reform in Ukraine, which is still ongoing, and consequently the war in Ukraine accelerated the demand for alternatives of directly observed treatment like digital adherence technologies. As you can see on the table, the proportion of TB patients monitored using video-supported treatment introduced by the National TB Program became almost twice more in 2021, when the COVID pandemic hit Ukraine. PATH supported the initiative launched by the National TB Program, and since 2018, we added an additional technology to support people with TB. Under a Stop TB funded TB Reach project in 2018-2019, we introduced a smart pillbox in Ukraine in two regions in selected districts. The goal of this small project was to just see whether this technology is acceptable for both patients and healthcare providers, and whether it is feasible to use it in the country context. As a part of this small project, we also conducted a survey for both patients and healthcare providers to see to assess their acceptability. This project demonstrated that the technology is feasible and acceptable and could be expanded to larger areas and geographies. In 2019, we started the implementation of the Ascent project in a consortium of partners led by Kainsevitt TB Foundation, and we implemented the standard wise pill produced plastic smart pill box, as well as added another technology, which was Sure Adhere mobile app, which was developed especially for video-supported treatment. All of these technologies were linked to the Everwell Hub digital adherence platform, which was accessed by healthcare providers who could monitor the adherence of the people with TB they were supporting. Ascent project included also the study aimed at evaluating whether the use of the technologies can improve treatment outcomes of patients with TB. In terms of the results of the research, as it was mentioned by the Eunice previously, we are waiting for the final paper to be published. So I will not cover this in this presentation. And now we are continuing the implementation of both technologies under Support TB Control Efforts in Ukraine project funded by the USAID. We have already scaled up the use of smart pill boxes and Sure Adhere to 11 regions of Ukraine, and we have plans for potential scale up to 16 regions of Ukraine by the anticipated end of the Support TB Control Efforts in Ukraine project. Here on this colorful table, you can see also the number of people with TB who had the opportunity to use digital adherence technologies. If we talk about the differentiated care pathway, we need to think about people-centered approach, which starts with the conversation between patient and healthcare provider and assessment of the patient's anamnesis of patient's situation, which is individual for every person with TB. And in Ukraine, it starts with the defining the treatment model and the need in social support, which is usually guaranteed under Global Fund granted projects. So with the implementation of the video-supported treatment by the National TB Program and Smart Pill Box implemented by PATH under different projects, options for treatment models for patients, like there were a little bit more than just two treatment models for patients. And if we use the technology, the next step is defining the place of receiving TB drugs. In Ukraine, it could be done in a region level TB facility or TB dispensary, in inter-district TB facility. And now Ukraine is also switching to family physicians who are responsible for the management of the TB disease and for the monitoring of treatment adherence. And sometimes it can be organized in other facilities like AIDS centers or other types of facilities. The key message here to say and to consider is that the need in social and psychological support should be provided based on the patient's needs, regardless of the defined treatment model. So it doesn't mean that if the patients received smart pill box, that then this patient doesn't need social support or psychological support. When I say social support, global funded projects in Ukraine includes small financial support for patients, like giving some phone vouchers for them, or food packages, like involving lawyers to support patients with documentation and other services. And complementary, the interventions carried out to form the adherence to treatment should be complementary and not mutually exclusive. So when we implemented the ASEN project in 2020, we tried to develop a differentiated care algorithm which was in line with the capabilities that the technology provided to us and the digital adherence platform, and as well as in accordance with the national guidelines to which healthcare providers should adhere. We, from the very beginning, we decided not to include SMS function in the differentiated care algorithm because of the confidentiality issues and because of the assessment previously done under TB Reach, when we talked to more than 100 patients, and most of them expressed their opinion that they were not willing to receive hundreds of SMS notifications every day, because as now with the digitalization and with the use of technologies by different like manufacturers and advertisements, we receive so many SMS notifications daily. So we didn't want people with TB to feel overwhelmed with these notifications. In terms of healthcare provider side, they were supposed to register patients on the Everwell Hub and digital adherence platform. Then they were supposed to review every day the list of people with TB on the platform and react on missed doses. If a patient missed 1 day of dose, a phone call should have been happened to understand whether the dose was taken, or whether it was a technical issue, or the technology didn't work, or the patient didn't take the smart pill box when the patient went to visit the relatives, or like what is the situation. If the dose was not taken, the healthcare provider was supposed to mark it on the calendar in the digital adherence platform. And if non-adherence continues after day 2, day 3, then probably other type of support is needed for the patient. Probably social support could be added, probably psychological support needed, probably, and lastly, probably the technology is not suitable for this patient, and maybe we need to change the treatment model. This was the initial plan to implement the differentiated care algorithm, and what kind of challenges we faced. And these challenges resulted in sometimes in lower levels of provider engagement with patient and technology. And I subdivided the challenges into 2 categories. Let's start with the DAT intervention design related ones. As I already mentioned, SMS functions was not used due to confidentiality. We only implemented welcome message which each patient received if patient's phone was entered in the digital adherence platform. This SMS notification only said that welcome, you are enrolled on a smart pill box or video supported treatment. Please adhere to a treatment and good luck. We noticed that for most of healthcare providers working in an additional system in the digital adherence platform increases the workload for them, and this was noticed when we noticed that as we supposed, healthcare providers didn't confirm missed doses. They didn't register support actions on the platform because initially we wanted them to register each phone call, each visit, each support action, like involvement of a social worker on the platform, so we can have all this information for the ASCENT research. But in no health facility we had such an approach that healthcare workers did this due to the high workload, and they have to work in other digital systems introduced by the National TB program and by the Ministry of Health of Ukraine. And of course, there were some context-related challenges which influenced the differentiated care algorithm. One of them is the health reform, which also influenced the high workload of healthcare workers, because in some locations it meant the reduction of staff, the reorganization of staff, the reorganization due to the simultaneously ongoing decentralization reform in Ukraine. The reorganization happened in a very different way in each region of Ukraine where we worked. And we worked in Western Ukraine, and we worked in Eastern Ukraine, and in Southern Ukraine. And it was a really different approach in each of this region to the health reform. Lack of healthcare providers in some facilities. And then COVID-19 started, and then the war, and I will not talk a lot about the COVID-19 because I think that the challenges related to this pandemic is similar to all the countries which faced it. But regarding the war, I have the separate slide later. So what we did to try to address these challenges, and I would like to start with the key message, which is that we need to involve the end users from the very beginning and throughout the digital adherence technology implementation, and make them feel this ownership of the DAT intervention, make them feel not the end users only, but also the developers of the digital adherence technology intervention. And the second part of our success is the ongoing routine monitoring of the intervention and of the country landscape, and adapting to all the situations happening. We conducted in-person visits to health facilities to provide ongoing support and monitoring. And I highlight that the visits, that in-person visits have much more opportunities than online monitoring of the intervention. We established trustful relationships with the healthcare workers, and that allowed us to discuss in depth differentiated care issues, as well as any challenges related to the health reform or any challenges related to their work and engagement with the people with TB they were supporting. In order to address issues with the lack of healthcare providers, we improved differentiated care through providing a wider access to equipment. We distributed tablets into regions where TB nurses had no personal computers in their health facilities. So when TB doctors were too busy, TB nurses could support them in this routine daily monitoring and reviewing the list of patients on digital adherence technologies. And we conducted all the time refreshers trainings because of the staff rotation and reorganization resulted from the health reform, and interactive workshops with healthcare providers using sticky notes, dividing them into groups, and that also helped us to create this feeling of ownership for the healthcare providers. As the digital adherence technology is a new approach for the world, not only for Ukraine, it needs ongoing review. And our differentiated care model developed under Ascent initially, that I showed you a couple of slides before. It was optimized throughout the discussions with the healthcare providers, in line with the national standards, and in line with the challenging and changing circumstances for our country, which started with the normal life and then COVID-19 and then the war. So we have to adapt all the time to various challenges and situations. The above-mentioned optimizations form the basis for standard operational procedures that were approved in 11 regions of Ukraine, in which digital adherence technologies, I mean smart pill boxes, are used after the Ascent project, and they were simplified given the high workload on the healthcare providers. We removed the need to mark to confirm missed doses, because the red cell means red cell for the healthcare provider, and there is no need to recolor it from the lighter red cell to a darker red cell. That's what we heard from healthcare workers. Also, we established, we were trying to make this differentiated care algorithm as much close to the national standards as possible. And currently, we suggest switching to the other technology or to the other methods of treatment support if a patient misses more than 14 doses in a row or misses more than 7 doses multiple times. However, this does not mean necessary discontinuing the use of technologies, because the decision to stop using the technology or involving any additional type of support should be made during a conversation between the doctor and the patient, in line with the people-centered approach. And of course, right now, when we talk about Ukraine, I should mention the challenges related to the war, which the full-scale war started in February of 2022. We faced so many challenges in terms of the access to TB drugs. Patients and healthcare providers were evacuating because everyone cared about their lives at that moment. Now we have large number of internally displaced persons. We have air alarms happening regularly. Sometimes they are just alarms, and sometimes we have missile attacks throughout the whole territory of the country. And this influences the availability of healthcare providers, because they need to go to the shelter during the air alarms, and not only healthcare providers, but people and transportation challenges due to safety concerns, as well as psychological barriers, because priorities of people during the war are switching, of course, to protecting themselves and their loved ones. When the war started, we were trying to provide all the possible support to healthcare providers that we could do, and they did their best in order to support people with TB during the war. People with TB who could visit the health facility, they received TB drugs for 2 or 3 months Yes, before that, we recommended that the smart pill box contains a weekly or monthly dose of TB medicines, and when the war started, we started to provide drugs for a longer period. People who could not visit the health facility but remained in the region, healthcare providers arranged for local volunteers to make drug deliveries, or also involved post services, but if they were operating still in the affected regions. And digital adherence technologies and remote monitoring of adherence, it was so much help for healthcare providers during the war, and has proved itself as an efficient supportive tool, because they helped to ensure remote patient monitoring and follow-up, even when patients were fleeing to other regions, or healthcare providers could flee to other regions. Healthcare providers in most dangerous areas, they could work from any place and monitor treatment from bomb shelters. And here you can see on the screen the quote, which inspired me a lot, because in some instances, digital adherence technology became an additional tool of conversation of communication with the patient when no other means of communication worked. But in this particular case, smart pill box worked because the TB doctor noticed the green cell on the screen of the digital adherence platform, and she assumed that the patient was alive and safe. And this TB doctor is from Slovyansk, which is Donetsk region of Ukraine, which is 37 kilometers from the front line, as you can see on the picture. And such stories inspires a lot, and I'm so much proud, and I'm so much thankful for our healthcare providers who continue working to support people with TB. And I'm proud that we are able to support them with an efficient tool like smart pill box or other digital adherence technologies. And as a conclusion, I would like to highlight that in Ukraine, smart pill boxes have proven themselves as an efficient tool for ensuring controlled treatment of TB as well as TB preventive treatment. In terms of video-supported treatment, as it was initially introduced in Ukraine by the National TB Program, healthcare providers got used to this approach, which was already approved, and use ensured here was not so widely accepted by the healthcare providers. So if we have more than 3,000 patients who have used smart pill boxes in Ukraine, with the SureAdhere mobile app, the number is a little bit more than 200. So we prioritize smart pill boxes. Moreover, this technology can be provided to those patients who do not have smartphones, who do not have access to internet, and patient even should not have a cell phone in order to be able to use the smart pill box. Moreover, smart pill boxes proved themselves as an efficient tool during the war, because they reduce the number of travels people need to make. And due to security concerns and infrastructure challenges, we all understand that currently it is very important for Ukraine. Despite challenges with facility-based directly observed treatment due to the war, digital adherence technologies have improved drug intake control because of the above-mentioned points I mentioned when I demonstrated the quote from the previous slide. And the last but not the least important point to say and highlight that technology complements but does not replace healthcare professionals and face-to-face communication with patients, or not even face-to-face, but a communication over the phone, because it is important to maintain this communication, because interventions for adherence are based on people needs, provider resources, and community support. And selection of these interventions should be based on the individual assessment of the patient's needs. And the digital adherence technology becomes a magic stick in the hands of a professional healthcare provider who is able to make an efficient assessment of all the available resources and take into account patients' needs. Thank you for your attention, and I would like to acknowledge a wide variety of partners who and which supported us, international partners and donors and national partners and organizations who supported us in the implementation of the digital adherence technologies in Ukraine, and our contributions to the Digital Adherence Technology DAT Task Force. Thank you. Over to you, Ines.
Thank you, Vladimir. Very comprehensive presentation. Thanks for that. Are there any questions? I'm just having a look at the questions section. I don't see anything for now. Please post your questions in the chat. Just one thing that I wanted to mention, in line with Vladimir's reflection on the fact that using an additional adherence platform apart from the system that's already in place adds a burden to healthcare providers. So as the DAT task force, we've been working on solutions for countries to address this particular challenge, where the pillbox is directly integrated into country systems. It's not always possible to integrate the technology into a country system, but as much as possible, this is something that we really promote, because within the Ascend project and also as the DAT task force, countries that we've worked with, it has been one of the biggest challenges when you have these siloed systems, basically. So we did the first webinar that we did as the DAT task force was diving further into the selection of an adherence platform and also looking at how you might be able to integrate that into your country system and solutions that are available. So as it stands right now, we have the Pillbox API, which can be integrated into systems. We don't have solutions yet for other contexts or other technologies. But there are instances where other technologies have also been integrated into country systems. So I'd really suggest that you go back and look at that first webinar, looking at that specific topic. I don't see any questions. So I'm going to move on to the next slide. Please feel free to post in the chat. I know we're close on the end of time. So what I want to say in terms of the DAT task force is that we provide technical assistance to countries in planning for implementation and scale up of DAT. So that's all the way from budget development, proposal development, as well as identifying which technologies are most suited to the context, looking at the entire country system and providing recommendations for a specific country in terms of what would be most suited. And then we can also support in assessment of the country system and then how that might line up to DATs, but also assessment of digital adherence technologies if they're already being implemented. And then the last thing that I want to say is if you scan this QR code or use that website link at the bottom there, the www.tbdigitaladherence.org, you find a lot of resources related to DATs. And on that website, you will also find the Learning Hub, which is where all of the previous recordings and any documentation related to that particular webinar is published. So I would suggest that you go and have a look at that.